multiple things going on with the patient that you need to be aware of. So we'll start with reading the scale. So I'm going to go with good precautions. Is my scene safe? Okay. Hi, my name is Eric. I'm an EMT. Is it okay if I help you? One of your first findings is that once you ask if you can help them, the patient is unresponsive. Okay, is this my only patient? Do I need additional resources? I would log on my patient if indicated or if necessary. I'm going to go ahead and secure C-spine precautions by putting a collar on my patient. My initial assessment or general impression is that my patient has hit a tree with his vehicle and was ejected 30 feet lying in the position it's found. Is my patient responsive? As indicated, he's unconscious. Do I see any life-threatening emergencies I need to deal with? Multi-system trauma. What is my patient's chief complaint? The multi-system trauma. We're going to start over. Were you in the accident with them?
They don't fuck with
Okay. Is my patient's airway open? Okay, if the patient's airway was not open, I would go ahead and secure 15 liters with high flow O2 with a bag valve mask with adequate ventilation. So I see any life-threatening bleeding emergencies at this time?
Your patient, you assess an open leg fever fracture with capillary bleeding.
Okay, this time I want to go ahead and control the bleeding, and I want to sterilize the wound as much as I can. I want to split in a position of comfort. Ideally, I'd like to feel for a pedal pulse before and after I split the patient's femur. Okay, then I would go into CMSTP. I would check for motor sensory pulse. Due to the fact that the patient's unresponsive, I'm not going to get that. But I will feel for a pulse, as indicated. Based on the mechanism of injury, I'm going to go ahead and make my transport decision immediate and start to get out of here. At this point of the skill, I would generally take a sample history, but due to the fact that my patient is unresponsive, I'm not going to be able to get any signs or symptoms other than what the presentation is of the patient. No allergies, no medications, no pertinent medical history to speak of, no last oral intake, or events that led to other than the car hitting the tree and the patient being ejected by 30 feet away. Now I'm going to perform my full head-to-toe assessment by going into the patient's head. I'm going to feel from the frontal lobe, the parietal lobe, to the occipital. I'm going to feel back in C7, check my gloves for any bleeding. I'm going to check the ears and the nose for any cerebral spinal fluid or any blood. I'm going to open the patient's mouth. I'm looking for good oral hydration or any kind of indication of an occlusion, broken teeth, dentures that may compromise the patient's airway. I also want to check the patient's eyes to see if there are any reactivity. Eyes are pearl, perfect. So now I'm going to look at the patient's neck. I'm looking for tracheal deviation or any jugular vein distension. Okay, indicated flat neck veins. I want to go ahead and continue with high flow oxygen. I want to treat for shock as indicated and elevate the legs to make sure that the blood is flowing back towards the heart. Okay, without any exposure to the patient's chest or unnecessary exposure to the patient's chest, I'm looking for bruising, airway flail, and scarring. I'm going to check the integrity of the chest wall and the equal rise and fall of the chest. I want to go ahead and get these things over here. And I'm going to listen for lung sounds.
Assess decreased breath sounds on the left side.
Okay, if I have decreased breath sounds on the left side, I'm going to continue with high flow oxygen and treat for shock as indicated. I also have left-sided flail chest, which indicates that there are 3 or more ribs broken in 2 or more places on the same side. I want to go ahead and secure the left side of the rib cage with a trauma dressing, and I want to secure it snugly to the torso to prevent paradoxical motion. Without any exposure to the patient's, without any necessary exposure to the patient's abdomen, I'm looking for lacerations, penetrations, or eviscerations. I want to go ahead and palpate all 4 quadrants.
Assess a distended abdomen.
Okay, with the distended abdomen, I want to continue with high flow oxygen, treat the shock as indicated by elevating the legs, but this time I want to cover the abdomen to prevent further heat loss. In the lower part of the pelvic girdle, I'm going to press on the iliac crest, blend it together, check for the integrity of the pelvis.
The pelvis.
Okay, on a male, in the genitalia area, I'm going to look for a priapism. On a female, I'm going to look for bloody discharge in excess of 1,000 cc's. If there's no indications there, I'm going to go to the lower extremities. I'm going to go ahead and palpate DCAP, BTLS, just make sure that you know what they mean.
What does B stand for?
B,
B.
B,
DCAT.
B. Then I'm going to go ahead and feel for bilateral distal pulses.
No distal pulse.
If no distal pulses are indicated, I want to continue with high flow oxygen, treat for shock as indicated. I want to go into the upper extremities, looking for DCAP, BTLS as well. And I'm going to try to assess for bilateral radial pulses.
No distal